just for a visual impression.
Yes, sir.
Visible?
Yes, sir.
Yes, yes.
So, major obstetric history anesthesia, it is the preventable maternal death. So, obstetric hemorrhage should be anticipated and treated early so that we can prevent maternal death. And the physiological changes of normal pregnancy usually mask the clinical presentation in the early stages. That is what Shobika correctly mentioned, that you may not estimate the bleeding correctly. You may think it is a normal physiological change. Patient having a pulse rate of 90 or 100 is normal physiology. So if you miss like that, then you are likely to miss the bus and miss the major bleeding that is yet to happen. And visual estimation of blood loss is notoriously inaccurate for to assess hypovolemia. That is another mistake people commonly make. So any clinical evidence of maternal cardiovascular compromise may represent significant blood loss irrespective of the estimates. So there is no universal consensus on the exact deficit or definition of massive obstetric hemorrhage. But the definition, as she rightly mentioned, may be a blood loss of more than 1500 ml, which belongs to class 3 hemorrhage, fall in hemoglobin of more than 4 grams, the need for transfusion of 4 or more units of blood. These are the three things that are considered as the definition of massive obstetric hemorrhage. And what are the reasons for the poor outcome when you treat a massive obstetric hemorrhage? One is delay in the treatment. So you miss the bus by not following up the bleeding correctly, trying to prevent it or estimate it correctly. Unavailability of blood and blood products at the earliest level, inaccurate estimation, and every hospital should form a protocol. When you suspect a massive hemorrhage, you must form a protocol as to how to treat that. That may not be there because you come across these cases once in a rare while, and that is the reason why many of the hospitals miss the bus. Poor communication between the teams treating the patient, the inadequate organizational support, lack of blood bank, and all these things. And the main causes are, they can be classified as antepartum, intrapartum, or postpartum, as you said. And any bleeding from the genital tract after 24 weeks. Some people say it is after 20 weeks of gestation, is defined as antepartum hemorrhage. And the main causes of antepartum hemorrhage is placenta previa, placental abruption, or coagulopathies. And during hemorrhage, it is uterine rupture, laceration during vaginal delivery. Postpartum, it is uterine atony, placenta accreta or placenta increta, various types of placental implantation, and cervical lesion dysplasia. For the 4 T's are the main mnemonic you have to remember for postpartum hemorrhage. That is mainly for postpartum. And vaginal bleeding in placenta previa is classically painless, whereas pain due to ruptured ectopic or a ruptured uterus, they are all very painful. Whereas classical painless hemorrhage is usually placenta previa, and usually it occurs in the second or third trimester of pregnancy when the cervix starts to dilate. And postpartum hemorrhage caused by, remember, by 4 P's. One is the uterine atony, second is the trauma to the vaginal tract, third is the retained placenta, fourth is the coagulopathy. So the risk factors and prevention strategies are, uterine atony is one of the important risk factors because of over distension of uterus, which may be because of antepartum polyhydramnias, multiple gestations, or a big baby. All these conditions stretch the uterus too much, so the uterus does not contract properly after the delivery of the baby. And in these patients, avoiding prolonged labor by trying to give a normal vaginal delivery will definitely result in neutropenia. So avoid that. And prolonged third stage of labor may be also the reason for the PPH. And early use of prophylactics and active management of third stage of labor is important. And very rarely it may be abnormal presentation like various forms of placenta preta and preta perpreta, all these things. And nowadays, with the help of ultrasound, we can diagnose all these things right from the time of the placental implantation. That is why we do early ultrasound of patients, do it at the 51st day and during the first trimester 2 or 3 times to do the not only the placental position but also the scan the baby for anomalies. And another, as the labor progresses or even before the labor progresses, there may be placental abruption, abruptio placental, which will lead to bleeding. So prevention is early clamping of umbilical cord, prophylactic diseases, use of protonics, all these things will do that. And previous history of PPH, especially in patients with multiple pregnancies, they may have problem. And obese patients, previous cesarean, instrument assisted delivery, ketone products, febrile sepsis are all causes for PPH. And their steps in the management, you must recognize it early warning signs or hemorrhage, and always administer 100% oxygen by face mask. If the patient is pregnant, we keep her in the left lateral position, call for appropriate help, established to all these steps he has rightly mentioned. Immediately send blood for cross-match, arrange 4 to 6 units of blood and 4 to 6 units of fresh protein plasma. First you start with crystalloid like the normal saline in warmed water and replace red cells as soon as possible. The packed red blood cells can be given. Then you can try combination of in class 1, class 2, and class 2 and class 3 hemorrhage. Initial management can be tried with combination of crystalloids and colloids. Then send blood for basic investigations and start using thromboelastography at this stage itself. And use blood and fluid warmers, warming blankets to avoid hypothermia. RH negative blood can be given if grouping and cross-matching is taking time and the patient is deteriorating. Aim is to maintain normovolemia, monitor hematocrit, urine output, and hemodynamics. Prompt treatment of coagulopathy is present. Early planning of surgical intervention, conservative measures and pharmacological measures are not successful. And further management depend on the cause of hemorrhage, whether it is retained placenta or placenta preta. In all these conditions, sometimes we have to decide on early hysterectomy or early intervention with clamping of internal iliac arteries or embolization and all this. So when you start treating this hemorrhage, one major setback or complication is the patient developing coagulopathy. It is either due to the consumption coagulopathy or the other thing causing the what is called disseminated intravascular coagulation. So it may be because of consumption clotting, hemodilution of transfusion of crystalloids and colloids. So monitoring of patients with MOS, what we have to do is hemodynamic monitoring, urine output, hemoglobin, hematocrit, coagulation profile, especially platelet count, prothrombin time, activated partial thromboplastin time, and plasma fibrinogen level. This is considered the key factor because ultimately it is the fibrinogen which has to get converted to fibrin to form the clot. So nowadays we give more importance to fibrinogen level, and fibrinogen concentrates are now available. So the availability of this particular clotting factor has revolutionized the treatment of hemorrhage. So nowadays routinely measurement of fibrinogen is also done. And point of care testing is available in the form of thromboelastography or rotational thromboelastometry. And Targeted goal-directed therapy with specific coagulation factors. That is the advantage of doing TEG or ROTAM at the earliest with viscoelastic methods associated with less incidence of allogenic blood transfusions and thromboembolic events. And also the DAC is very much reduced by correctly treating the deficient factors with the help of this TEG and ROTAM. Use of blood products in the treatment is ideally cross-match specific blood should be given. In case of non-availability for emergency and the patient in a very bad hemodynamic status, you can go for O-negative blood. And infusion of large volumes of crystalloids and colloids have to be restricted. Earlier, we were trying to push too much of crystalloids and colloids to maintain the circulating volume. But this causes dilutional coagulopathy, metabolic acidosis, tissue edema, and tissue hypoxia. So that is where the TEG and ROTAM come for help, and we can identify the exact cause for the bleeding and correct it. The correct advantage is management of hemorrhage in war-wounded army personnel have been extrapolated to major obstetric hemorrhage. So the recommendations used are Axel plus fresh frozen plasma in the ratio of 1:1 and the early use of platelets. These are the three things that are given. And massive blood transfusion protocol should be followed present in delivery areas, keeping in view local expertise and facilities. So all obstetric units should have what is called the massive transfusion pack, which should consist of 4 units of O-negative blood, 4 units of fresh frozen plasma, and 1 apheresis pack of platelet. So O-negative, 4 units, 4 units FFP, and 1 unit of platelets. Ideally, fibrinogen concentrate and prothrombin complex concentrate also should be available, and these things have been now included in the pack. And this is the rapid transfusion. Whenever you want to replace volume in a major bleeding, your normal IV set with a wide bore cannula may not be sufficient to replace it adequately. So in order to do that, we may have to use a rapid transfusion system. It is called level 1 transfuser. For the benefit of those who have not seen that, you can see there are 2 packs. You can hang 2 units here, and as soon as 1 unit gets over, the other unit will automatically start flowing. So there is no interruption in trying to change the bag of fluids or the blood or whatever you are doing. So automatically it will start. So it gives you time to refill the other one. So there are 2 units which are there, which will rapidly do that, and they will warm the fluid also with a warmer inside. And this was earlier introduced in for liver transplant surgery, where they required a lot of blood administration. And later on, it was extrapolated or used in trauma victims. And now it is recommended for use in major obstetric hemorrhage also. The features of this level 1 rapid infuser are it has a fast infusion rate as well as it has a warmer. It's a D3 disposable tubing, and the flow rate can be anywhere between 30 ml to 1100 ml, keeping a maximum rate of 1400 ml also. The temperature of the fluid can be between 36 to 40 degrees Celsius. So they are trying to prevent the hypothermia. And there's a gas vent filter to remove micro bubbles from the gas in the line that results from heavy fluid being treated. So these are the features of that. How many fluids that you can use. So sometimes, in the exam, if it is a cardiac center where you go for your exam, they may have this machine kept in the viva, and they may ask you all the features of that. So it is better to know what are the things that we do that. Indications for use of this warmer is provide rapid warm fluids and prevent hypovolemia and hypothermia. Contraindications: you should not use the infuser for warming platelets or cryoprecipitate or granulocyte suspension. It is only mainly for blood and FFP and Patient monitoring during this procedure are vital signs, core temperature, IV integrity, hemodynamic parameters, and urine output. And goals for hemostasis are hematocrit of 27 to 30, INR less than 1.5, fibrinogen concentration more than 100 milligram per deciliter. What is the normal value of fibrinogen?
Should be more than
More than
250.
250 milligram per deciliter. Okay, that is the normal value of fibrinogen. And platelet count on more than 100,000. Core temperature more than 35 degrees Celsius. And this is thromboelastography. It's a machine, I don't know how many of you have seen. And it produces gives the value for platelet content, clot formation, clot strength, and fibrin clot leakage, and clot lysis. These are the 4 things that it does to assess. And the common question they ask you in the exam, the difference between thromboelastography and ROTAM. What is the difference? The main reason why I have given this picture is to understand the difference.
In thromboelastography, the pin will rotate, sir. In TEG, sample will rotate, sir.
So there is a torsion wire with a pin, and you can see this is the heating element of the sensor. So this cuvette or the container rotates here. Whereas in ROTAM, the torsion wire will rotate, the container will remain stable. Okay, that is the difference. And this is the usual presentation that you get. This R time is the initiation time from the starting of the coagulation factor until it starts. It is called the reaction or R time. After that, it forms the clot with the maximum amplitude within about short time, and then it remains there for some time, and then it starts getting lysis. This is the fibrinolytic time. So the coagulation and fibrinolysis both are depicted here. So these pictures are given in your IVA to identify this, because PEG and COM and ROTAM are now frequently used in major hospitals. And also, you are expected to know what are all the things that you are to. So here you can see the R value, R time period of latency from the time the blood was placed in TEG analyzer until initial fibrin formation. This represents the enzymatic portion. It takes about 4 to 8 minutes time, and the R value 11 to 14 minutes. FFP, if it is increased to 11 to 14, we have to give FFP 8 ml per kg. If it is more than 14 minutes, this the initiation itself is taking too long a time. Then you have to increase the dose of FFP to 15 ml per kg. And this is how the prolonged R time will be shown. Whereas shortened R shows a hypercoagulable state, and the K time is the measure of the speed to reach certain level of clot strength. So from the starting point of the coagulation to reach the maximum strength of the clot, that is called the K time, and this is about 1 to 4 minutes. It has an alpha angle which measures the rapidity of fibrin build-up and cross-linking, that is the strengthening of the clot. This represents the fibrinogen level. Okay? And that is about 45 to 75 degrees. It is the value of this R alpha angle, which is about 45 to 75 degrees, which indicates the fibrinogen level in the blood. And here you can see there is a normal R, prolonged the K, so it shows the platelet defect. And MA is the maximum amplitude in the direction function of the maximum dynamic properties of the fibrin and platelet bonding via GP2B and 3A in the platelet, represent the ultimate strength of the fibrin clot. So the maximum MA amplitude should be 55 to 70 millimeters. That is the value for MA. And it is 80% due to platelets and 20% due to fibrinogen. And this is the picture you will have when you have a platelet deficiency and a fibrinolysis deficiency. And LY is lysis 30, measures the rate of amplitude reduction 30 minutes after the maximum amplitude has been achieved. So this is the time interval. Normal is about 7.5%, and it shows the value there. Take with heparinase. Heparinase is an enzyme breaking the heparin that is being administered. So heparinase patients, when you want to test the clotting ability, heparinase patients prior to heparin reversal with protamine, you have to use this enzyme. This test may prove particularly useful during long pump runs, deep hypothermia, and use of ventricular assist device and complicated major. That is, this point is not in reference to massive obstetric hemorrhage. This is where patients have been already heparinized and we want to do the testing. We have to use the heparinase enzyme to break down the heparin before we reverse and try to do the measurement. And to remove the platelet, add frequently. FDA removes that it binds to GP2 3B3. So this is also more of interest of TEG in other patients with deficiencies. And this picture is commonly shown in the Viva exam. So to identify the various types, I think I have shown this in one of the ASCIIs also. So the A is a normal one with a normal R time, normal K, maximum amplitude and all these things. The second one, the anticoagulant in hemophilia factor deficiency. So there is a prolongation of the R time. You can see from the reaction, from the time you put the sample in the egg machine to form the clot, you can see how much of time it has taken. So there is a prolongation of R and K time. And the maximum amplitude is also decreased. It's not what you shown in the earlier picture. And when you have a platelet blockers like the thrombocytopenia or thrombocytopathy, R time is normal. Initiation of clot is normal, but the K time is prolonged and the MA is also decreased. Maximum amplitude is decreased. And in fibrinolysis, you can see there is a R time again is normal, but maximum amplitude is very much reduced, and lysis takes place at the earliest, much earlier than what it should happen. And this is hypercoagulation. The R time is very much shortened, and the maximum amplitude gets prolonged for a longer time. So there is a prolongation of coagulation. And the DAC, there will be two stages. One, in the initial stage, it will be a hypercoagulable picture. Then it becomes a hypocoagulable with a prolonged R time and a very small amplitude of clot formation. So this will be two stages of DAC. So this picture you have to remember well, because this is commonly asked in the examination. And with the TEG value, what are the treatments that you can think of? TEG and ACT combined more than 140, the treatment is to give FFP. If R time is more than 10 minutes, you saw how much of FFP we have to give, and the time is more than 10 minutes. Normal time is 4 to 8 minutes. More than 10, you have to give FFP. And K time more than 3, you have to give cryoprecipitate. And alpha angle less than 53, cryoprecipitate plus or minus platelet. Maximum amplitude less than 50, it is mainly platelet deficiency, so you give platelet. Lysis time more than 30%, 33%, you give tranexamic acid. So these are all the ways by which you interpret and treat the PEG values. And stages of hypovolemic shock, we saw that. So the first stage is compensated, second is mild, moderate, and severe. Blood loss amount in the heartbeat, normal vasoconstriction, redistribution of blood, and arterial pressure is almost normal here. So orthostatic changes, arterial vasoconstriction, and here is where you will have the increase in diastolic blood pressure and decrease in pulse pressure. And all the changes get broken, and the patient goes in for the other features like everything, heartbeat, arterial pressure, respiration, mental status, urine output, capillary refill. These are the things that you have to assess the degree of. And types of platelet implantation, this is just for the knowledge sake. This is placenta previa. Previa means in front. So it is almost occluding the cervical canal. Placenta increta is partially implanted. This is the normal position of placenta where it should be there. And then this is placenta increta. Percreta just come out of the serosa also, apart from the passing through the endometrium muscular cord as well as serosa. It is called placenta percreta. And this is how the various positions of the babies will be there in patients with various types of placenta previa. And this is about the cord position in those patients. And pharmacological treatment of uterine atony. Once the postpartum hemorrhage is due to lack of uterine contraction, first drug of choice we always give oxytocin. Then methergine, earlier it was used, but in rare cases, some obstetricians still prefer to use it because it is a much more powerful uterotonic agent. And there is another prostaglandin F2A, it is called Hemabap. It is given 200 micrograms IM every 15 minutes with a maximum of 2 milligrams. Misoprostol, misoprostol prophylactic, and prostaglandin E2, prostin E2, they are all actually given. So these are various methods and administration of these drugs. Then invasive treatment, often with the respective sectors, include intrauterine balloon tamponade, compression sutures, angiographic arterial embolization, arterial ligation, and hysterectomy. These are the comprehensive treatments that are available for as a invasive method when pharmacological things are failed. This is the intrauterine balloon, which is inflated to tamponade out the bleeding vessels. Then this is another method of doing that. And these are the what is called the sutures, B-line sutures, which we give to contract the uterus. So the sutures are taken like this. And this is embolization, uterine artery embolization, how it is done in the radiology suit. And this is another method of suturing that uterine artery ligation, internal iliac artery, which is close to that. So you do that. Before you ligate the internal iliac, you can try uterine artery ligation. If it fails, you go to the main feeder internal iliac artery. And cell salvage can be done. This is the machine that is used for cell salvage. So you can collect that, especially in Jehovah's Witness patients who have placenta previa. With a rare or a patient with a rare blood group, this can be done. So this is how it is done. And disadvantage, it will be mixed with amniotic fluid and it may not have the coagulation factors. That is there. We have to risk with this particular. Coming to DAC, it's an acquired syndrome characterized by systemic intravascular coagulation. Coagulation is always initially in the evening. So systemic activation of coagulation, intravascular deposit of fibrin, depletion of platelet and coagulation factors occurs because of that. Then thrombosis of small vessels and mid-sized vessels, which leads to organ failure. Because of consumption of all these platelets and coagulation, patient starts bleeding and death happens. That is why it is called disseminated intravascular coagulation. So even though coagulation occurs inside the vessel, ultimately patient bleeds to death. So wherever you have tried to start an IV line or poke the patient, from all these sides, patient will be bleeding. And this is the obstetric causes. Of course, we have seen all that. And the main reason is associated with endothelial damage leading to activation of intrinsic and extrinsic pathways, preeclampsia and eclampsia, conditions having non-specific or indirect action, then amniotic fluid embolism, gram-negative septicemia, and saline abortion, all these things also can lead to this particular problem. And the mechanism of DAC we have already seen, because vessel wall damage, activation of coagulation factor, platelet activation, fibrin platelet thrombosis. This leads to coagulation factor deficiency, low platelet, fibrinolysis activation, end organ damage, appears gradually, and generalized bleeding tendency. Hemorrhagic manifestations involving skin and mucous membrane. There may be ecchymosis, petechial bleeding, bleeding from the gums, hematuria, GIT bleeding, venipuncture oozing, and intracranial or intracerebral hemorrhage. So these are all the ways it can manifest. And what are the thrombotic manifestations? It can be in the form of neurological or multifocal coma, dermatological with focal ischemia, renal with cortical necrosis, GIT with acute ulceration and bleeding, vascular occlusion causing pulmonary infarction and vascular gangrene. And what is the algorithm for evaluation of factor deficiencies? Platelet and the PT and APTT normal. That means it is a factor 13 deficiency may be there. Prothrombin time prolonged, APTT normal, it is a factor 7 deficiency. Prothrombin time normal, APTT prolonged, it may be factor 7, 9, 11 or 12 deficiency. Actually it should be 9, 11 and 12. Prothrombin time prolonged, APTT prolonged, it is factor 2, 5 and 10 deficiency. And how do you treat DIC? Remove the underlying cause, replace depleted factors. FFP provides sources of most of the factors. Cryoprecipitate provides fibrinogen. Platelet and blood support are used. Cautious use of heparin. Initial stages when there is a usage of all the coagulation factors to cause intravascular thrombosis, the small doses of heparin will try to reduce that. So this is a very tricky situation where heparin has to be administered quite early, and then you have to correct all the deficiency of factors. This is the way you treat the DIC. This is a very challenging situation. And of course, these are all the definitions of massive transfusion, which may be a off-root question in Viva if you are talking about this. So just for knowledge sake, I included these slides. And 3 approaches to massive transfusion are transfusion management of the can be lab-based, can be ratio-based. It is 1:1 frozen plasma and to RPC, point of care testing driven. So these are the 3 methods. And the best protocol is ratio-based to start with, and then go for lab-based treatment. This is how the platelet transfusions and cryoprecipitate transfusions are done. So the adverse effects of all these things are hypothermia, citrate toxicity, volume overload, abdominal compartment syndrome, transfusion reactions like active hemolytic transfusion reaction, or transfusion related acute lung injury, transfusion associated cardiac overload, and major allergic reaction. And activated factor 7A, which we mentioned above, requires adequate fibrin and platelets to be effective. So it was originally thought it would be a good panacea for all obstetric hemorrhage, but later on it became unpopular because one, it is a very costly thing. To treat a patient with factor 7A, it requires at least 1.5 to 2 lakhs worth of drugs. And, the mechanism how it is acting is increases the tissue factor occupancy, and in pharmacological doses binds to activated platelets, activates factor 10 independent of tissue factor. These are the methods by which factor may concentrate works. When you want to do cesarean hysterectomy, the anesthetic challenges are it may be classified into semi-elective or emergency. Okay. When the obstetrician is not able to control bleeding with the pharmacological method, when the patient is stable and you plan to do the hysterectomy after informing the relatives and the patient, that may be called as semi-elective. But once you have tried all the sources and the patient is deteriorating and gone to the class 4 stage, and there is no other way except to do a cesarean, then it becomes an emergency situation. This can happen, elective you can do in placenta accreta or placenta perfecta also when you diagnose it antenatally. And PPH with failed conservative or interventions land up in emergency hysterectomy. So anesthetic techniques used are combined spinal epidural. Continuous spinal is also another technique where you can put in a very small gauge, 30 gauge catheter into the rubber knot space. First, give a small dose of say 0.75 to 1 ml of local anesthetic. Then, as the level required, you can give incremental doses. Keep the catheter for 24 hours and then remove it so that it will form a whole fibrosis, the inflammatory reaction, and close the hole so that no post-dural puncture headache occurs. And hybrid operation cases where combined embolization followed by hysterectomy can be done in the tertiary centers nowadays. There are facilities like that where they can try embolization, and if it fails, they can convert that case into case of hysterectomy. So these are the things that we have to very major obstacles.